Hello, this is Michael Altos, and we are finishing our discussion of the GI system and antihistamines, and this is part 3. Now we're going to discuss other medications that have an effect on the GI system. The first is metoclopramide, or Reglan. This is a drug that binds to muscarinic receptors in the GI system. It increases sphincter tone of the lower esophageal sphincter. Does not really have any effect on gastric acid pH. Reglan is primarily used to stimulate upper GI motility, which means to increase gastric clearance. And this has been used in lots of full stomach patients, like traumas, obese patients, pregnant patients, patients with bad gastroesophageal reflux disease. Patients who receive opioids are known to have decreased gastric emptying, and metoclopramide might not help with that. But it does seem to help in diabetic patients who have gastroparesis. If it's given 10 to 20 milligrams IV about 15 to 30 minutes before induction of anesthesia, this is the proper time frame for achieving the effect of gastric emptying. Many people recommend to give it slowly over 3 minutes because rapid administration can cause cramping, and occasionally it can cause some mental status changes. And some of these effects may be offset by the use of atropine. Metoclopramide is also a dopamine antagonist. Now that's not its primary mechanism for the effects we've just described, but we should be aware of this because it may explain why metoclopramide has some antiemetic effect, and we don't really use it as a first-line treatment for PONV anymore. And also some of the side effects, for instance, dystonic extrapyramidal symptoms and akathisia, and especially with long-term use, patients may develop some of these side effects. And as we've discussed previously, metoclopramide is avoided in patients who have Parkinson's disease. Other side effects that we see with Reglan may include hypotension or dysrhythmias. Dysphoria and sedation, as I mentioned before, have been seen, although they are rare. And you may want to avoid them in patients who have seizures and who are taking MAOIs or TCAs. Metoclopramide may also inhibit plasma cholinesterase activity, which would be an issue with succinylcholine or ester local anesthetics. I can't see that I've ever seen anyone change their practice with respect to those drugs because of metoclopramide. Erythromycin is an antibiotic, but it also happens to have an effect on the GI system in that it increases lower esophageal sphincter tone, it promotes GI motility, and people have actually used erythromycin to treat diabetic gastroparesis and to increase gastric emptying. We will pause here for just a moment in case you have any questions. And now we're going to speak for a few minutes about postoperative nausea and vomiting, which is a major topic and really outside the scope of this lecture. And you're responsible to be aware of the different patient-specific and procedure-specific risk factors for postoperative nausea and vomiting. We've already discussed a lot of anesthetic agents and techniques that have an effect on it. And of course, when patients are nauseated, we need to rule out things like hypotension and hypoxia, hypoglycemia, increased intracranial pressure, and gastric bleeding, just to name a few examples. Some very well-known studies have shown that patients can be quantified as having a certain degree of risk of postoperative nausea and vomiting. So we see here a patient who has 10, 20, 40, 60, or 80% risk of nausea and vomiting based on predisposing factors. And so we see that if we give one intervention, one drug, we can decrease their risk by a certain amount. But as we give a second, a third, and a fourth kind of drug, we can have a substantial effect on a patient's risk of postoperative nausea and vomiting. So that might not be a big deal when a patient only starts out with a 10% risk. But a patient who has an 80% risk really recognizes a benefit as we add on different kinds of agents for postoperative nausea and vomiting. And so that's why we should be aware of many different drugs, because sometimes patients may need several different modalities. We know that there's a vomiting center in the brain, and the vomiting center is affected by your vestibular system, which is your balance system. It's affected by some of the things I discussed before: hypoxia, hypotension, pain. It's affected by periphery things like the GI tract and the pharynx. And then this CTZ, the chemo trigger zone, which is full of all sorts of receptors that our nausea medications target. Dopamine, serotonin, different muscarinic, histaminic, opioid, and other kinds of receptors. The first class of drugs we'll discuss are the serotonin receptors. 5-HT3 is a subset of the serotonin receptor. And we're all familiar with ondansetron or Zofran. There are other drugs in this same class. These drugs are most effective when given at the end of surgery. Zofran is given at a dose of 4 milligrams IV, other drugs at different doses. And the most common side effects you should be aware of are headache, and then perhaps some effect on liver enzymes or constipation. Dexamethasone we've discussed earlier, and this is an effective drug for prophylaxis of postoperative nausea and vomiting. The mechanism is unclear. It certainly has an action in the CNS, probably in the medulla. And a dose of 4 to 5 milligrams at the induction of anesthesia is most effective. It's as effective as a dose of ondansetron. And usually only a single dose is given. There's not a lot of data to back up a second dose if they continue to have nausea. No significant adverse effects, and we are all familiar with the side effects of steroids. Butyrophenones are drugs that we've discussed before. These are the antipsychotic drugs like haloperidol or droperidol. And these drugs are also very effective for preventing postoperative nausea and vomiting, having an effect primarily on the dopamine receptors. Droperidol, which is not really available anymore, was given in the range of 0.625 to 1.25 milligrams, and it also was just as effective as 4 milligrams of Zofran. Haloperidol is still available and could be used in certain situations, usually at a dose between 0.5 and 2 milligrams. Usually most effective when given at the end of surgery. And side effects, as we've discussed in previous lectures, would include sedation, sometimes anxiety and restlessness and dystonia. Droperidol, as I said, is no longer available because it inherited a black box warning from the FDA describing a risk of developing torsade in patients who have long QT syndrome. Looks like the T fell off my slide here. Now the truth is this is controversial because, first of all, it wasn't clear how clinically relevant this was, especially at the low dose of 0.625 milligrams. Additionally, haloperidol and Zofran and many other drugs also have a risk of torsade with long QT syndrome. Nevertheless, droperidol took it on the chin and has pretty much fallen out of availability. But if you do use butyrophenones in patients, it's recommended to have some ECG monitoring for a couple hours afterwards. Antihistamines, as we discussed earlier in this lecture, like diphenhydramine or dimenhydrinate, which is Dramamine, are also good drugs for nausea. They seem to work in the vestibular system, as well as having an anticholinergic and a sedative effect. And these drugs have been long used for motion sickness and may be beneficial in the perioperative period as well. Typically, I'll start with a Benadryl dose of 12.5 to 25 milligrams IV, and I know that the most common side effects will be sedation, dry mouth, and urinary retention. Phenothiazines, most commonly promethazine, which is Phenergan, or prochlorperazine, which is Compazine. These are also dopamine receptor drugs, which work in the CTZ and other parts of the CNS, and may have antihistamine and anticholinergic activity as well. Promethazine is my first-line rescue drug for postoperative nausea and vomiting, usually with a dose of 6.25 to 25 milligrams, usually given IV or IM. If you're using it prophylactically, you would give it at the start of anesthesia. Side effects include sedation and some extrapyramidal symptoms. And promethazine, due to some risk of vascular necrosis, is now recommended to be given either intramuscularly or else as a slow IV infusion. We discussed metoclopramide earlier and discussed its central dopamine receptor effect and the fact that it increases GI motility. These two effects may contribute to its antiemetic properties, but it's really not a first-line therapy for nausea anymore. People would give 10 milligrams IV. The timing was not really well defined. Neither was the efficacy at this dose. And side effects, as we've discussed already, hypotension, tachycardia, and a risk of extrapyramidal symptoms, especially at high doses and in patients with Parkinson's disease. Some of these side effects can be minimized if the patient is treated with benzodiazepines or antihistamines concurrently. Anticholinergic medications, most notably scopolamine, have been used very successfully for nausea. By antagonizing the muscarinic receptors in the cerebral cortex and the pons, as well as some antihistamine effect, these drugs can be very effective for nausea. And the scopolamine patch takes anywhere from 2 to 4 hours before the effect can begin, but can last for up to 72 hours. And this is important for post-discharge nausea and vomiting, which can be an equally difficult problem. The most common side effects of scopolamine are blurred vision, dry mouth, dizziness, and occasionally agitation. We have not seen nearly as much of an effect on nausea with IV anticholinergics like atropine or glycopyrrolate. So those are not typically used as anti-nausea medications. There are other treatments that have been described, like ephedrine, which is not a first-line therapy and doesn't have much evidence to back it up, but a lot of people will tell you that a dose of IM ephedrine at the end of surgery will decrease nausea and vomiting. And the mechanism is unclear. It's not only related to maintaining good blood pressure. There's some other mechanism that's not well defined. Propofol has been used as an antiemetic. A 10 to 20 milligram bolus in the IV in the PACU may be a rescue therapy and in desperate situations, but probably with a short duration of action. And many of the other things that have been described, some have more evidence than others. Supplemental oxygen, increased hydration. You'll see nurses having patients inhale the fumes from an alcohol swab. Ginger, as we've discussed before. Acupressure at the P6 wrist point. And stimulation with transcutaneous electrical nerve stimulation. That's it for this lecture. Please let me know if you have any questions, and we will look forward to seeing you in class.